Okay, so as far as agents, I'm recording. So we're moving on to what's considered the inhalant anesthetics, which are considered, they're part of the drugs, but they have to be delivered via inhalation. So they have to be inhaled. And what I'm going to talk about is when we deliver inhalants, what's important is they have to have a carrier gas. So these are often, they come as a liquid, and then that liquid has to be vaporized and inhaled to achieve anesthesia. So for all intensive purposes, I'm going to mainly, the delivery agent is oxygen. So oxygen is considered the carrier gas for the anesthetics. Now, some of inhalants talk about, or that we'll talk about, they came as a liquid and they could have been delivered as a liquid, but the current anesthetics that we use, the current inhalants, have to be given via, some type of carrier gas. And ours use oxygen. So the primary ones that you guys will deal with in practice are going to be isoflurane and sevoflurane, and those are known as halogenated compounds. That's the type of gas they are. Now, I'm not going to talk about desflurane. Desflurane is used in human medicine. Right now, it needs a special vaporizer, and it's pretty expensive. It could eventually make its way into veterinary medicine. Maybe some research facilities and teaching hospitals might be using desflurane, but for all intensive purposes, you guys will have access to ISO and SEVO. We have both of them at the school. You'll use both of them in surgery rotation. Now, you probably have heard of nitrous oxide, which is considered laughing gas. So if you go to the dentist and you inhale and you feel kind of like, you feel euphoric. It's not an inhalant anesthetic. It is a gas, and I will talk about it a little bit. Now don't worry about enflurane, but I do talk about halothane. Now, halothane is not currently available, and neither is methoxyflurane. But again, for the board exam, the way the new agents are compared and the way they're graded, they compare them to the older agents. And so on the board exam, you could see questions about halothane or methoxyflurane. So I will discuss those, but you will use ISO and SEVO. And then no one really uses ether, but I'm going to talk about it. So again, the ones you'll need to know for the test are, the primary ones are ISO, SEVO, halothane, and methoxyflurane, are those four. And I will briefly discuss nitrous oxide. Now, if you think about ether, sorry, did I skip a slide? Why did it skip? Okay, that's weird. So the inhalants, as far as ether, it is not real currently used. Now, if you remember in the movies, sometimes someone has a rag and they put it over someone's mouth and then they pass out. That was ether. And so it used to be just put on a rag and you would inhale it and it would produce anesthesia. Now, if you think about it, nothing really on a rag can be very controlled. But it was a fairly stable agent, which I'm going to talk about. ISO and SEVO were kind of unstable. So it was stable. Not a whole lot of cardiac output, rhythm, blood pressure issues, good muscle relaxation. But the problems with ether was there was a lot of tracheal and bronchial irritation, so it could cause a lot of coughing, post-op irritation. Induction and recovery could be prolonged because we weren't really controlling the amount. And some nausea and vomiting could also occur, were some of the common post-op effects, and highly explosive. So that was like used ages and ages and ages ago. And then they have come up with what's called the halogenated organic compounds. And like I said, the most common that you currently use is the isoflurane and sevoflurane. Now, they come as a liquid. When they are at room temperature in a bottle, iso and sevoflurane are a liquid. But you have to deliver them to the patient through something called a vaporizer. Now, I typically go over vaporizers when we get into anesthetic equipment, but I'm going to have to talk a little bit about them. So if you've ever seen on an anesthetic machine, and there's pictures in your book, is, there's the unit, and it tells you what type of vaporizer. Now, what is specific is isoflurane needs an isoflurane vaporizer, and sevoflurane needs a sevoflurane vaporizer. They are not interchangeable because the gases have different properties. And you can ruin a vaporizer if you put the wrong agent. So, and I'm going to tell you guys, this is a practical tip. If someday you're in practice and you accidentally do it, and you're like, oh my God, I screwed up. I mean, and some people don't like to get in trouble, but you have to tell someone, because the vaporizer would have to be sent to the company, drained and cleaned, and you cannot safely deliver the agent. Okay, so they have their specific vaporizers for a reason. And they're color coded. Like I'm going to tell you right now, isoflurane is coded purple. The bottle is purple, the top is purple, the vaporizer is purple. Like it usually has like a purple strip, and it has the name. It says isoflurane vaporizer. And then sevoflurane is yellow. The top is yellow, the box is yellow, the vaporizer is yellow. So there is a color coding system, and that kind of is so to help you. Halothane was red, and I want to say methoxyflurane was orange, but I'd have to check on that. So I do want you to know the colors. Isoflurane's yellow, isoflurane's purple, sevoflurane's yellow, and halothane is red. So really just to know those three main ones. Now, when you put the liquid into the vaporizer, the way that the vaporizer is hooked up to the anesthetic machine, you will turn on the oxygen. And when you turn on the vaporizer, the oxygen flows through the vaporizer and it picks up, well, then the the liquid will vaporize. And the oxygen molecule carries that vaporized anesthetic to the patient. And then they inhale the agent. So oxygen is the carrier gas for isoflurane and sevoflurane. And it was the carrier for halothane and methoxyflurane. So we use oxygen as our carrier gas. Now, there's a fair amount of physiology and pharmacology when it comes to understanding the inhalants. So the liquid anesthetic is vaporized and it's mixed with oxygen. Now, the two ways that we can give this to a patient. Now, what you guys are going to do in surgery is you give the propofol, the induction, you put the endotracheal tube in, and then you hook up a breathing system. There's tubing, and then that hooks up to the ET tube, and then through that tubing, the oxygen and inhalant can be delivered via the endotracheal tube directly to the lungs, and they inhale the oxygen and anesthetic. Sometimes what we do is we'll mask a patient, and you'll hook up a mask, and you'll hook it up to the breathing system, and you'll put it over their nose, and then they can inhale it that way. Now, it is more efficient to use an endotracheal tube because you deliver it directly to the lungs. Sometimes there's some leakage with the mask, but masking a patient is another way to deliver gas to the patient. Once the animal inhales the oxygen and inhalant, okay, oxygen diffuses into the lungs down to the alveoli. And at the alveoli, which is the air sac in the lung, there's capillaries, there's blood supply. So what's going to happen is that oxygen and anesthetic are going to diffuse into the bloodstream. And then the blood goes to the brain. And then the brain is going to uptake the inhalant anesthetic, and you're going to achieve anesthesia. Now, how the gas does that, I'm going to talk about some things, some concepts, but there's that diffusion gradient. If you remember, I keep saying this in classes, things like to move from high to low, okay? So when an animal first inhales anesthetic, the concentration is high in the alveoli and it's low in the blood. So by nature, that anesthetic wants to move to the blood. While the animal is on anesthetic, it's going to continue to diffuse, because what's going to happen is the blood's going to go to the brain's going to uptake, okay? When that blood goes back, it's lacking some of that anesthetic, so it's going to continue to uptake. Now, what happens when you turn off the gas, when you turn off the inhalant, the concentration is higher in the brain, it's going to diffuse into the blood, and the animal is going to exhale the gas and they're going to wake up. So you have to think about the drug is constantly moving back and forth. So it goes from the alveoli to the capillary. These agents are also very lipid soluble. So again, the brain is a highly lipid environment. That's why the drug moves so easily from the blood to the brain, because of that lipid solubility. Okay, so that's how the gas moves. Now, when you hear about concentration gradient, all that means is, where is the concentration greater? So obviously, when you're first inducing an animal and you're giving a high level of gas, that's when you're going to have your highest concentration. Eventually, what happens is it moves, some is going to move to the fat, to the brain, to the blood. Then you're going to kind of maintain even levels. And then when you turn it off, it goes from the high concentration back to the blood, it's exhaled. And that's how the drug moves back and forth. Now, let me also talk about a concept really quickly. Just the drugs isoflurane and sevoflurane are highly volatile anesthetics. And what that means is that how quickly does the liquid want to become a gas? I'll give you an example. If you were to spill it on the floor, sometimes people go to fill the vaporizer and they spill it. By the time you go get paper towels and you go get a towel and you come back, a lot of it's going to be gone. It turns to a vapor very quickly. And a good way to understand this is that an isoflurane vaporizer, the highest amount you can deliver to a patient is 5% ISO. That's the highest the vaporizer goes. If you were to pour isoflurane on a cotton ball, say put it on a cotton ball and put it in a mask or on a rag or whatever, you would reach concentrations up to 30% isoflurane, which is highly overdose, because it wants to become a vapor very quickly, and you would reach very high amounts. So that's why these agents need to be given to our patients in a vaporizer that's controlled. You can control the amount and you can control the percentage it's delivered, because again, we don't really want to go above that 5%. That the vaporizer stops at that. So, and very rarely there's very rare times I have an animal at 5%. That's a very high amount of isoflurane. And I'll talk about like what's normal, what you should deliver, and whatnot. But that's kind of, so when we talk about distribution to the tissues, it depends the blood supply to those tissues. So again, lipid solubility is what determines how readily that agent dissolves, okay? Now again, fatty tissue, the more fatty tissue, the more uptake. Now, I would say if I have an overweight patient, I wouldn't say you have to deliver more anesthetic, because you may be doing the math in your head and go, well, if they have a lot of fat, isn't it going to take? It's the blood supply, some of that, there is blood supply to the fat, but the amount that gets to the brain, it doesn't really, their weight doesn't really factor in this equation. Now, the partial pressure in the brain is the partial pressure what's in the blood in the alveoli. So again, how much we're delivering and how quickly it gets to the brain is kind of maintaining that gradient. So I'm going to be talking about turning them up, turning them down, and what's happening to the level of anesthetic. Now, the halogenated compounds in general, this is isoflurane and sevoflurane. Some of this pertains to halothane, but they are a CNS depressant, so they are going to be anesthetized. They should be unconscious. They should have muscle relaxation. They are not analgesic. There is no analgesia with isoflurane and sevoflurane. All the drug is doing is keeping them from moving, keeping them from recognizing that they're having surgery. So, you still, like I've told students before, I could get any dog in the kennel, no drugs on board, put a mask on them, restrain them down, and do anything we need to do. But I'm going to be using very high amounts. It's going to be very stressful for the patient. And when I turn off that gas, they're going to feel everything I did. So that's why you pre-med, you give inductions, is so that, again, I want to use as little of these drugs as possible. The goal of your pre-meds and your induction agents is to try and minimize how much of the iso and sevo that you need to use. That's kind of the goal of good balanced anesthesia. They can get hypothermic. The higher that they're on, the longer that they're on. These drugs cause vasodilation. Iso and sevo, of all the anesthetics you guys will use in your patients, these are the worst for hypotension and vasodilation. So again, the longer they're vasodilated and they're CNS depressed, their temperature is going to go down. You also have to watch blood pressure. I kind of joke with isoflurane. Sometimes I move the vaporizer back and forth and I call it dial a blood pressure, because I can turn them down and blood pressure goes up, and then I turn them up and blood pressure. So sometimes you can see just turning the drug up and down. My goal is always to run the lowest amount I can. Now, some of you guys are working in practices, and some of you guys have maybe shadowed and done whatever. All that matters for my class is what I say. So I'm going to tell you, there are some clinics that'll put them on 3-4%, and they're like, oh, you just leave them there. Well, I've had patients sometimes down to 1%, sometimes down to 0.5%. And the thing is, if you never try to turn them down, if you never try to turn that anesthetic down, you never know if they can actually use less of the anesthetic. And again, there's some potent side. Everyone thinks that iso and sevo are safe. They are safe because they can be rapidly metabolized, but they can cause a lot of side effects when you use high amounts. So my goal is to always turn the patient down to the lowest I can. But sometimes people just, you can put an animal on 3% and they'll survive surgery more than likely. But what if they could have survived at 1.5%? And that was better for them physiologically in their body. So I'm just saying, you're going to hear me say that over and over again, because it does depress cardiovascular function. So you'll notice when you guys turn on, you'll give your propofol, intubate, and then you'll be in surgery, and you'll notice your heart rate will start to come down. And usually what will happen is, what I like to see is it comes down and it plateaus. But it is a cardiovascular depressant. Their heart will be slower than it was when they were awake. Their respiratory system is also going to pre-depress. But this is key: dose-dependent ventilation depression. The higher the percent you're on, the worse the breathing is going to be. Now, what it does two things to respiration. First of all, they don't breathe as often. And the deeper they are, they don't breathe as deep. So you can see, sometimes you'll see very short, shallow breaths. And that might be a patient I try to turn down to see if I can get them to breathe a little deeper or breathe a little more often. Again, so the higher the percent, the worse the heart rate, the worse the respiratory rate. But something that I hope you guys have been getting, you've been doing radiology, you've been sedating patients. And I still have students struggle with this concept. There is only one drug that you guys are using currently that drops the heart rate dramatically. What drug is that?
Is it dexdomitor?
Dexdomitor. So, and that's pretty dramatic. You guys have seen, AJ had heart rates in the 40 to 50, which didn't bother me. He was fine. That's to be expected. I don't expect that kind of heart rate with just isoflurane and sevoflurane. You're going to get bradycardia. Their heart rate should slow down, but the only drug that you guys are using that really dramatically drops the heart rate in those really low is the dexdomitor due to that vasoconstriction. This doesn't vasoconstrict. This does the opposite. These drugs vasodilate. Now, what have I told you? If the animal gets vasodilated, what can the heart do to try to fix that? Does it speed up or slow down?
It speeds up.
It does. So sometimes what happens when they vasodilate, the heart's natural reaction is it wants to fill the pipes. If you think about vessels like pipes, and the heart's job is to keep the pipes full. Well, if the pipes are vasodilated, the heart's like, ooh, they're bigger, I have to work harder to fill them. So sometimes when you get massive vasodilation, you can get an increase in heart rate. So that's why I want to, as a student, you're like, just tell me what is important, what I need to know. Well, I'm just telling you it's variable. You're going to get some heart rates that do go down gradually. But if you have them at high percentages and you're making the vasodilation worse, you could see the heart rate speed up. And if you guys remember when we talked about heart rate monitoring, and an animal has an elevated heart rate, everybody wants to think it's pain and they're light. Well, and that's true a lot of the times, but remember, sometimes the heart rate will increase to try and increase blood pressure or in the face of vasodilation. So you can't ignore, if you always think that they're light and you always turn them up, you can make the problem worse. So that's when you have to look at your other monitoring. If the heart rate goes up because they're light, well, I probably would have a higher respiratory rate, a higher blood pressure, maybe some jaw tone. But if their heart rate goes up and their respiratory rate's low and the blood pressure's low and they, maybe their eyes are central and their jaw tone's loose, everything else is telling me that my animal looks deep. That's not an animal I want to turn up. So this is why I'm going to keep hammering. You have to use multiple values to try to figure out what's happening. So these are just some of the effects. Some things of the adverse effects that we worry about is that you can get some increased intracranial pressure. If we have like brain tumor, head trauma patient, which, you're not anesthetizing a lot of those dogs, we want to try to use lower amounts. A lot of times those dogs need lower amounts anyway. It does not cause seizures. It doesn't lower the threshold. So these agents can be used in seizure patients. The thing I worry about, one thing I hate about isoflurane is that it does cause vasodilation and hypotension. Now, when you have low blood pressure, I've told you guys the mean blood pressure that the kidneys need is 60. And I don't like the systolic below 100, and I don't like the mean below 60. Because what happens is then blood flow to the kidney is compromised. Because the body's like, I can't send blood everywhere if my blood pressure is too low. So the body starts to prioritize organs. And when you start getting too low, they're like, sorry, kidneys. Now, if blood flow does not go to the kidney, two things don't happen. We're not getting rid of wastes and making urine. But I also worry about oxygen flow to the kidney, oxygenated blood. And then what happens if the kidneys don't get oxygenated blood? The nephrons, those little individual working parts of the kidney, they can die if they get hypoxemic. And so what happens is you can cause damage to the kidneys. And I worry about that, especially, maybe it's a 1-year-old dog for a spay and, the dog's pretty healthy. But what if you've got that 10-year-old dog for a dental and maybe the kidneys are, and then you could make it worse. So I worry about that. Probably a little more in my geriatric patients, but every patient you should watch blood pressure. It does cause hypoventilation. So again, hypoventilation is two things: low volume, low rate. So they're not breathing as deep and not breathing as often. And one thing, there's lots of things I want my students to know, but if I could get this burned into your brain, what is the consequence of not breathing as often? Don't think about oxygen right now. I just want the lungs get rid of CO2, okay? So, and they have to exhale. So if I'm not exhaling as often and I'm not exhaling as deep, there is a potential to retain carbon dioxide. So instead of getting rid of it, it stays in the bloodstream. Well, what's the consequence of elevated carbon dioxide? Eventually we get to what's called
Poisoning, right?
so you get, well, like carbon dioxide, yeah, and if you're thinking of carbon monoxide, but if you think about carbon dioxide retention, it'll cause what's called respiratory acidosis, which it's not good for the cells. Respiratory acidosis, because if you remember from anatomy, digging deep, when you have an elevated CO2, what happens to the pH of the blood? Does it go up or down?
And it go down.
It goes down. They're inversely proportional. So the higher your CO2, the blood, the pH tries to compensate. And when your pH drops below base, that's acidosis. So the only way to fix this is you either have to, now normally what I do is I try to turn down my anesthetic and see if the patient will breathe more. So, that's like the number one thing I do. A lot of people on a test, a lot of students want to say, turn up the oxygen. Well, this is the other concept. I had a class that wanted to put it on a coffee cup and give it to me as a gift, but I said, turning up the oxygen does not fix everything. It's a common answer I get on almost every question. The problem is if an animal is not breathing and you just turn up your oxygen on your machine, like you turn up the flow, it doesn't just magically go into the lungs and fix. So you have to ventilate. You actually have to squeeze and breathe for the animal. This is why if you watch surgery or you've been in a practice or people occasionally squeeze the bag, even on an animal that's breathing normally, I always give them a supplemental breath. But if I have a patient that's hypoventilating and has an elevated CO2, I might be breathing for them once a minute, twice a minute. And the more I ventilate is I blow off that CO2, and then hopefully that CO2 comes down, their pH should go up, and that's my goal. But what I want you to really understand is that I don't like that answer. I don't like just turn up the oxygen, because again, if an animal is not breathing, it does nothing. It does nothing. They have to inhale it. And if they're depressed, they're not going to inhale it, no matter if you turn it up. So turning the anesthetic down is a good answer. Ventilating your patient is a good answer. That's what I want. I'm literally giving you a gift, because I'm probably going to ask this question probably 500 more times. That's exaggerating, but you get my point. I just want you to know that from a practical perspective, because I don't want you to think you can just turn up the oxygen and then, because now the problem, let me mention oxygenation, because if you guys are thinking in your head, well, if they're not breathing enough, they're not taking in enough oxygen. Oxygenation has different kind of rules to it. You're going to see, it would take a long period of them not breathing well to see a change in like the pulse oximeter. Because remember, your pulse oximeter is measuring their oxygen saturation. So that's a little different. Now, again, one of the answers I had wanted to see on the test when I talked about the pulse ox, if you have a low pulse ox reading, I always check the probe first, because a lot of times it's just a probe issue. It fell off, it's dry, it's sitting in poop, it's not in the esophagus the right way. There's lots of reasons. But if you keep moving your probe and wetting the tongue and you keep getting a low oxygen, and then I verify that I have oxygen in my tank, my oxygen's on, because I tell you it's equipment, then you need to bag your patient. And if you squeeze the bag and force oxygen in, does it improve the reading? And sometimes it does. But there's a lot of things to check first. You can bag the animal like 10 times. If it's a probe issue, it's not an oxygen issue. That's why I always tell you guys, like, check the probe, check your tank, make sure your tubing is hooked up, and then ventilate. Now, what I'm going to do, what I'm going to talk about next is there's some things about the gas anesthetics you need to know that are very board question motivated. Not that you're going to talk about this every day in practice, but there's things about the drugs, and we have to talk about vapor pressure, partition coefficient, MAC, and solubility. Because in your reading, and I don't have the book in front of me, there is a chart in this chapter that shows you all of the anesthetic inhalants, and then it tells you their vapor pressure, their coefficient, their MAC, and that's how the agents are compared. We compare agents based on this information. And let me just touch on the first one because I know we're almost done, but let me talk about vapor pressure. Vapor pressure was kind of what I was alluding to. It's a tendency of an inhalant anesthetic to vaporize into a gas, to go from a liquid to a gas. And so it determines how readily the agent is going to vaporize. Now, the way that agents vaporize is based on the temperature and the agent. Let's just think broad for a second. If I poured isoflurane on the floor in a cold room and a hot room, which one would vaporize faster, do you think?
Hot room?
The hot room, right. So temperature, now what you'll learn, like I said, I have to talk about vaporizers. This is kind of a chicken and egg thing. I'm like, should I talk about vaporizers first? I'm like, no, I'll talk about the drugs. Those vaporizers are temperature controlled. So inside, there is a mechanism that sets a consistent temperature so that there's not an influence of the environment. But I will say a short little story about this. I belong to, it's called Vet Anesthesia Nerds. It's a Facebook group. I think anybody can join it. They post lots of cool cases, and people from all over the world are part of it. But a friend of mine that worked in Anderson posted to the group, and they were having trouble keeping their dogs asleep during, and they were troubleshooting the machine and troubleshooting whatnot. And what they found was their OR was so cold, it was influencing the vaporizer. And what the vaporizer was delivering was not what the dial said. So if, you're supposed to use it, now an OR is usually colder than your rooms in the hospital. You don't want a hot OR for bacteria, also so people don't pass out during surgery. So the OR is always colder, but their temperature had dropped when they got the vaporizer tested. Even though the vaporizer said 2%, it was not delivering enough anesthetic. So there is somewhat of an influence, like if you used it in a cold barn versus a hot room, it can influence it. But for the most part, the vaporizer unit internally controls the temperature. Let me stop there because I don't want to like cram this in at the end. But we're going to start to talk about these concepts. Are there any questions based on what we kind of just talked about?